Right, whenever you're ready.
All right, cool. All right, last lecture of the year, guys. Super excited. You know, we took a vote a few weeks ago on who we wanted to have as the case discussants in our final lecture of the year, and the fellows unanimously picked, the three of you. And that's obviously no surprise because you guys are all super resuscitationists, obviously, experts, and we all look up to you guys. So very excited to pick up as many teaching points from you guys as possible. What we can do, Mike couldn't make it today. He had an emergency to deal with. So if there's a second-year fellow who wants to join this expert group, I welcome you guys to join. Any volunteers?
Just you and Joanna.
Stefan. Yeah, Stefan.
Oh, man, my students
Take
are
that
big.
one. Alone, Sean. I'm just like, waiting on to come for a second.
My shoes are big shoes to fill. I don't think I'm tall enough for that.
Or have enough hair,
It's fine,
right?
we'll tag you in. We'll yeah.
He's the tallest of the group, though.
All right, guys. My last bit of this is obviously, we want to maximize the time we get to hear from Dr. Glassby and Dr. Ward. So fellows, if you guys have additional thoughts or questions, share them on the thread and then on the chat, and then we can go ahead and ask them. Want to get as much from you guys in the next 37 minutes as possible. There's no right answer. Obviously, it's just about how you guys would approach this case. I will say this is one of the toughest cases I've dealt with in fellowship. One of those cases that just make you rethink everything because everything is coming at you at once. So hopefully a great learning case. All right. So, case starts off. You are starting your shift. It's just, it was the end of a swing shift, and the previous attending says, "Hey, there's a really sick patient in the ER they just called me about. They're asking for help, but it is 11 o'clock, so why don't you go take care of them?" I call the ER. They say, "Can you please come help? He's extremely short of breath. He's tachypnic in the 40s. His chest actually looks horrible, and I definitely don't think he's stable for a CT. And I think it might be the flu because he was recently diagnosed with it." I think they obviously failed to mention is that when I come down there, he's extremely young and he's morbidly obese, right? And I wish they kind of started off with that. So I find out from talking to him that, this is around December time, and he's, having this cold-like symptoms, worsening shortness of breath over the last week. He did get diagnosed with the flu. He's been on Theraflu for 3 days. The ER so far, like every patient that walks in, he's received a full sepsis bolus and he's on broad spectrum antibiotics. So quickly look at this chest X-ray. That's what you see. And, you feel a little sweat coming down. And, these are some labs, 7.37, 32. He's oxygenating well. He's currently on BiPAP on a PEEP of 20, but his pulse ox is in the, high 80s, low 90s. Dropped it down to 12 and his oxygen started to improve, and we can touch on that. He's got an AKI. His last creatinine was normal. He's got a lactate of 5.1. His CK is 2.3 thousand. Minimal troponins, and there you see his CBC. He is flu positive, but otherwise the stat viral panel and some of the serum bacterial labs are all negative. The procal is at 60. So, I prepared questions for the three of you guys, and so I think Jared, we'll start off with you first. You have this patient in front of you. You're seeing him in the ER. Obviously certain things need to be done. The biggest thing is that, the giveaway is that he's breathing in the 40s, and then you see that chest X-ray. What's your approach next?
I mean, so my question is does he need an airway right now, and how bad do I need that CAT scan? Right, you got a young guy, so young people walk in, young people got to walk out. And so I would tend to probably be more aggressive with him than what I would with, if they were 80, right? It's not that you change your care or limit your care, but you treat young people differently.
Yeah, I agree with you, man. Right, that phrase is so innate in me now. Is that the young people walk in, they have to walk out. That your attention is all going to him now. And you're asking the right questions: is do I need to intubate now, or can I? And is he stable enough for CT? Let me ask you
I don't
this.
see anything on, like, I mean, I know his physical exam is probably terrible, and I understand that he's probably breathing in the 40s, but I also don't understand why they put him on a PEEP of 20.
Right.
Right, so I think if you work the PEEP down and now you're on like a PEEP of 12 or like something lower, because clearly he doesn't need a PEEP of 20, he's oxygenating just great.
Right.
He's
Yep.
not retaining, so I wonder if some of his tachypnea was because they put him on too high of a PEEP. So
Yeah.
I would probably immediately lower that down because that's bonkers. And I would probably just stand there and see how he did, but nothing right now is screaming that I need to intubate that guy in the ER. And to be honest with you, I don't think getting a CAT scan is gonna change
Right.
my overall management. I mean, I would probably put a focus on him, make sure he doesn't, I would, to make sure his RV's not blown out, because if the RV's blown out, then I may be more inclined to scan him, but that's just because I would be looking for a PE, but you could also argue that you would just empirically treat him with heparin and just get him out of the ER. My vote would be to drop his PEEP down, see how he did. If he looked good, I would just get him up to the intensive care unit.
Absolutely, man. I mean, I couldn't agree with you more. I feel better that you said that, because that is what I did, right? I don't feel as comfortable intubating a patient this critically ill, especially the young ones, without my ICU nurses that I trust, because I want everything to be ready.
And I would argue that right now, you don't have a must intubate scenario. You have something that would be modifiable from his work of breathing perspective, and you have a gas that shows he's oxygenating and ventilating adequate for the time being. And like the physiologic reserve that's involved is sort of a judgment call, but he's also young. So, I mean, young people can breathe a little fast for a period of time, and you can take a moment to get them into it.
Dave, what was his minute ventilation? Was he like ripping down like liters?
Like
with
15,
every
17. Once I dropped it down to 12, it was still 15 to 17. He was still tachycardic in the 130s to 150s. It was all sinus, and he was still breathing in the 40s, even after I dropped down. But his O2 did improve. It went from like the high 80s, low 90s, up to like the high 90s after dropping the PEEP down. I don't know if any of the fellows care to explain that.
But you said it was in the high 80s with a PaO2 of 370 something?
Yep.
I mean, the alveolar were just too over distended. Yeah.
Yep,
I mean,
absolutely.
that's
Yep,
what I'm
absolutely.
assuming with the high peak.
Yeah.
Yeah, you're still eventually being able to transfer the oxygen across. So that's why you may get a discrepancy between your arterial and your pulse ox. Okay, so right, I think we agree that we defer CT. We take him upstairs. I think the question is that, given that he's still having this insane work of breathing, he's still breathing away in the 40s, 50s. He's a critically ill patient. And there's a potential scenario where you guys end up for intubation. So, I think I'm uncomfortable with, I don't know if you guys are, but, you've adjusted the PEEP down. It's been you were able to bring up pretty quickly, but it's been a good 30 minutes. He's still breathing away in the respiratory rate of 40s, and his heart rate's still in the 150s. Did focus him. It's hard to get views because of the obesity, but very hyperdynamic LV. The RV is dilated. The best HAPSI I could get serially was 0.9. Keep in mind, he did receive 4 to 5 liters already of fluid. He is right now perfusing well. His extremities are warm. Cap reflow is less than 2. So, I think question is, are you making adjustments to antibiotics, to any other meds? And, that was really a question from Mike. And then, Dr. Glasper, a question for you. So, I think given that he's sustained breathing away in the 30s to 40s for, almost an hour and a half now, you made any other adjustments that you can with the BiPAP, but he still looks like he's in respiratory distress. How are you approaching the intubation here?
Well, so first is determining, I let often, especially if this patient's awake, it sounds like they're awake and alert, I will let them guide that decision a bit. If it's not a determination that has to be made where we are deciding to take their airway, you got to factor in the patient themselves. So if they are feeling that fatigue, then yeah, that's definitely one of those situations where you just need to listen to them, because they'll often know before you do. So it sounds like you're describing the situation that he's essentially fatigued and you need to intubate. Yeah,
what ended up happening is, initially he's young, right? He's very with it. He's absolutely scared of
Been at home
ventilating,
for a while.
and he refused to get intubated. We brought the discussion up, and he's like, "I refuse to have that happen. Why should this happen to me?" And then you start to see a bit of a change. The nurse complains that he's a little more tired, and then you get a repeat gas. And this is after being in the ICU, where you kind of made a discussion with him, and you did say that, hey, look, I'm worried you might get worse, so I'm going to preemptively line you up. I put a central line in and art line in, but then I get a repeat gas, and this is what I see. The pH has gotten worse, and the CO2 has gotten up. And I'm concerned that he's tiring out.
Yeah, absolutely. So, for multiple reasons, you decided that you need to intubate this patient. So you're pre-oxygenating as best you can, maintaining non-invasive support. You've already, secured excellent access and then monitoring, anticipating hypotension. And then you're setting up for, an airway the best way you know how, which is, don't choose a different way to do something when you're in a period of extremis. This is something where you go back to your training and go to like the most straightforward, first pass success is what you need. So for me, that is every single time a hyperangulated video laryngoscope. This has been looked at. We are much more effective at it, and a rigid stylet, and then having all your additional airway adjuncts available and be anticipating really difficult airway features, and then also be anticipating somebody who, is going to de-recruit probably pretty quickly. It looks like you were able to walk down that peak quite a bit, but you also have progressively worsening hypoxemia. And so, when you know that in using, paralytics are associated with better first pass success, it's still the right thing to do, but you also need to be prepared for de-recruitment that occurs during that, and overcoming that with positive pressure upon like your initial first breaths once you pass the tube. So a PEEP valve super important, and having the entire team ready for anything, because certainly this is you're painting the picture of a difficult airway.
Yeah. So did you already say Precedex and ketamine and intubation straight from BiPAP? Is that where you went with it?
Maintaining BiPAP, yeah.
So, quick rapid fire. So pre-oxygenation, I hear BiPAP and then a bag valve mask with a PEEP valve on. Is that correct?
Yeah.
Yeah, but I don't know if Lindsay touched on it, but for me, I would put this guy on like high PEEP, 100% FiO2, and like probably would have already put him on some Precedex while you lined him up. And I would be pushing ketamine to dissociate him on the BiPAP. But like the second he went out on the BiPAP, I would go. I would not bother trying to bag him up, because I don't think you're going to get enough seal on a bag and get positioning to like.
So I'm a no bag person. So I'm a BiPAP, keeping the mask on. Your BiPAP, if you have an excellent seal, that is your pre-oxygenation.
Yeah.
And so, yes, so ketamine is an excellent agent. And then I found that, folks, I'm not going to add Precedex on top of it, but just the stage where they are now relaxed after the first dose of your sedation, and then I'm still going to paralyze this patient. So then I would be able to then keep the mask on until you have them completely apneic during that period. And you're able to get, with an excellent seal, I usually see their oxygen saturation rise during that process.
Yeah. But it's also like have respiratory just keep a hold on the mask, and you just pop off the side, so that when you're ready to go, they just pull the mask off and then you go. So this is like a.
But I keep my hands, and I basically hold it the same way I would a bag valve mask, and I just pull their face up into the mask every time. So, because they're going to relax as soon as they've gotten that sedation. So you just don't have to obstruct in the interim.
Does it change your approach about switching to that bag valve earlier than later if I say that the patient has a beard?
I just, personally, I'm never, ever bagging, ever. I do true RSI. So like I would use the BiPAP to your advantage and because you've already, I'm assuming that you haven't told us otherwise, you've established a good seal and that mask is on, use that for your entire pre-oxygenation phase. until you are ready for your first attempt. And I agree with taking the straps off, having that all teed up, like everything's ready to go for a very smooth transition.
This is what Weingart refers to as DSI. Like,
Yeah,
this is a delayed sequence intubation.
Are you using a paralytic in this era?
yeah, I personally am, yeah, unless there's any other.
Are you? Because if you're gonna do it delayed, then there's like, no use in the paralytic, right?
No, well, it's like modified, right? Like it's like whatever you think is gonna give you the best view of the airway.
When he's referring to like the Weingart referral to like the delayed sequence intubation, it's about creating space and time for appropriate oxygenation and using light sedation to get you there. It's not necessarily doing what you would do in the operating room with a bag valve mask and propofol.
Mhm.
It's doing it in an ED or an ICU setting with something like either Precedex or ketamine at a lower dose, and then allowing that time to be a little bit longer where they're like a little out of it, and allowing that to be part of your strategy for intubation. Because you're literally sitting in the room, you're not setting and forgetting it. You're not giving a dose of, or starting Precedex and leaving. You're using that as part of your procedure for the airway control. But yeah, I'm gonna paralyze this patient for sure. First pass success is like super important.
Yeah, and also like, we're just looking at this guy's like oxygenation status, obesity, like you could say like, oh, don't paralyze because he needs to maintain spine, he's already failed.
That's not.
He's already.
Right, but he already failed,
Yeah.
right? Like he's already failing spine. It's not like, now, if you were to say, on the previous gas where he was 737, 390, and you were gonna go to intubate him, I may not necessarily paralyze him then because he's maintaining oxygenation and ventilation on his own.
Sure.
He has failed.
This is-
Right, so like this is,
insane.
this decision is intubate, if you can't intubate, cut his neck, right? This is not like, I'm gonna try to maintain spontaneous breathing in a patient who's a difficult airway, because he already failed spontaneous breathing.
And when you just, I know like, it's scenario change, but when you do your delay and your list, what do you do? You go like 200 ketamine and 10 aliquots, or like what do you, how are you?
It depends on how big they are, right? So like, let's say like if there are 100, so normal sedative doses, 2 mg per kg.
Right.
So like, most people are gonna be between 70 and 100, so I tend to give them a 50 dose aliquot, and then I may like just do small, like 1 cc, which I think is the 20 or something like that.
It's
You
really
see
small.
them, you see them, right? You give them 50 and you watch and you wait, because ketamine's onset of action is like within 30 to 45 seconds, like it's rapid. It's not atomidate rapid, but it's pretty rapid. You'll see them. Typically, I'll just have them like talk, and then you'll see them stop talking, and then you'll notice the eyes.
I'm just looking for the nystagmus, yeah, because the talking part,
Yeah.
and they can talk through even the dissociation, because they can be confused, and you can misinterpret that as, and wanting to give more, if they have nystagmus.
They have nystagmus.
Because they could say crazy stuff, if
Is it
monsters are chasing them, but as long as they have nystagmus, you're in a good place.
So the 2 times, the reason I ask is the 2 times of these ketamine, I found myself having to reach and ask for more.
Always, yes.
Because I gave it to them and they were still like way too awake. And it was like 100 like milligrams,
So I'm always calling for a total dose of ketamine that's usually at least 200 milligrams.
Because I think they come in 200 milligram vials.
Yes, I
Right, that's
usually
what I'm
just,
saying.
I say drug 200,
Like,
and then, and if I'm doing this as a part of a delayed sequence intubation, no one else is touching this ketamine except for me. I'm actually gonna do it as a conscious sedation, so I'm gonna push the pen myself. And that's because if you're truly not ready to you're ready to push the paralytic and then intubate. If you are, then you only have so many hands, and so you'll use somebody else to help you. But otherwise, if you're gonna be in more of a I'm in the room, because this scenario it wasn't painted this way, but you might have a patient who is actually acutely agitated and hypoxic, and that's really that clear delayed sequence intubation timing. This guy was just really tachypnic, it seemed like, but if you have somebody who is acutely agitated and hypoxemic, they will often need things like ketamine, and sometimes you need to even give it intramuscular because you don't even have an IV. So.
And I don't know, this guy's on vasopressors. And I've got epi in my hand.
Right.
Because if Uday's saying his TAPC sucks and you're gonna intubate this guy, his right heart's gonna fail.
Right, as I'm assuming why he chose ketamine is, that's what I'm assuming why he.
No, you can choose ketamine for a bajillion reasons.
Yeah.
I don't think it has to do with the effects of the right heart, because I think that's like voodoo science. But I think this guy's gonna crash when you intubate it. What happened, Uday?
Can't wait.
Sorry, we got distracted.
No worries. That's all amazing. I've never felt comfortable taking control of the meds because the nurses seem to have a lot of complaints about it. But I do agree. I really like that trick of, pushing the meds in aliquots by yourself, because you want to see, slowly how they respond to it before you pull the trigger on the paralytic. Rock or sucks?
Honestly,
What was his last line?
honestly, in this instance, I don't think it matters, but his cram was already up, so I probably would, I always offer rock.
Yeah.
Unless there's like a myasthenia patient or something like that or not myasthenia, because you can get rock, but the other one, whatever the other one is, where you need, where sucks is the paralytic of choice, or in a seizing patient, I almost never choose sucks in a colon.
Right on. All right. There's one last thing I wanted to touch on. So you intubate him, and Dr. Glaspie, maybe you can speak on this because I've seen you do this before, and I've kept that trick ever since. Is that you have intubated the patient, you're bagging him, and now you have to put him on the ventilator. You're concerned about de-recruitment. How are you switching him over from bagging him to the ventilator to minimize de-recruitment?
Yeah, clamps. But keep in mind that this is also something that I'm not asking someone else to do. I would, because I've had folks cut the tube, inadvertently. So, because clamps can damage the tube. But take clamps, wrap some of the, not paper tape, the plasticky tape around each prong, and then clamp.
Awesome. I will say
Very
I've done that
good
before, and people have looked at me crazy, and I said, "Don't look at me, look at Dr. Glaspie." All right. So, as expected, you intubate him, and then he immediately crashes. He's persistently hypoxic. His PO2 is in the 70s. You're doing everything you can, trying to adjust the vent, trying to recruit him, but now his perfusion is starting to get worse. You look at the focus again, just to make sure there's no pneumothorax. You've got good lung sliding throughout. His heart rate is still in the 140s to 150s. It's all sinus. The LV is insanely hyperdynamic, and then his TAPSE is still pretty reduced. Despite all your bedside measures, he is still persistently hypoxic in the 70s. What are you guys thinking of doing next, and how are you preparing for that? Or what are you doing while preparing for that?
I mean, it's to be honest with you, it sounds like this guy is just Florida right heart failure from ARDS, and now you put him on, now you intubated him, and so the more PEEP you put in, the worse you're gonna be. So honestly, right now, without any other advanced modalities, it's most likely put him on some form of milrinone, inhaled epoprostenol, low-dose levofed, possibly most likely vasopressin. I'd start him on vasopressin first, and I'd be sending him up to flip him.
Yeah, it's team and dedicated respiratory to get you inhaled epoprostenol, because that takes a while.
Yeah, my steps would be vasopressin, a low dose epi or levofed, and start him on milrinone, inhaled epo, and flip. But I would do all those things at the same time.
Yeah.
Right on. Awesome. Pretend that we use sucks, so short acting, even if he's somewhat obese. Is this nonsense, or is there some sense to it? Waiting for the patient to be paralyzed before proning.
No, because even if you use sucks, if that was the case, then I would just tell them to push 100 of rock. At this point, I don't really care about their goals for biz monitoring and things like that. This guy's hypoxic and has to go on this. He's tummy time as fast as possible.
Yeah.
And so if he had gotten sucks, I would just push rock.
I would just push rock.
And if he had gotten rock, I may just give him another dose.
Yeah.
Right on. What other vent things are you guys doing while you're preparing to prone this patient? Are you keeping him at that high PEEP of 20 because you're not really sure if it's working or not? And on top of that, you're concerned about the RV.
I mean, is he with a PEEP of 20, are you still maintaining plats under 30? Or did you just put him on a PEEP of, all right.
Yeah, his peak pressures are in the low 30s, his driving pressure is 11 to 15 when you're on a PEEP of 20.
So to be honest with you, in this instance, because I don't know how to do optimal PEEP when your driving pressures stay the same and your peak pressures are under 30, and when you have like a difference between like 12, 14, and 16, like let's say with people 12, 14, and 16, your driving pressure is the same and your plateau pressure is under 30. Like, I don't know which one is the optimal peak. Is it 12 or is it 16?
But
In this guy's case, I would pick the lowest possible peak that gives you the same like driving pressure.
Yeah.
And if your driving pressure for some reason worsens, when you go down to a certain peak level, I would stop. And I would go back up to the next peak that gave me the lowest possible driving pressure with a plateau under 30.
Right on. And I know we all know that if Mike were here, he would list out every article for ARDS ventilator management. You know, he would advocate for 4 to 6 cc per kg, driving pressures at, obviously all the goals. He would say, titrate your pH to greater than 7.2, and continue to adjust that way. I will say that in this case,
in all seriousness, you do want to pick the lowest possible tidal volume for him. And honestly, I would, but like, you're in a bit of a bind because you can't let, like, I would argue almost against Mike a little bit right now, because if he is in any way, shape, or form hypercarbic or acidotic, you're just going to worsen your pulmonary vascular resistance. So I don't know if I would necessarily let him tolerate acidosis as well as I would just a normal ARDS patient.
absolutely. Where do you guys fall on giving bicarb right before you intubate it, or right now when the pH is 7.2?
I wouldn't give it. No, he's not. He's sick, but he's not sick enough.
Right on. Right. I agree with that. All right. So the prone journey, you guys prone him. So initially, after proning him, he responded to prone positioning, high PEEP in the first initial pH or PF ratio after an hour after proning, 96. Big improvement from the 60s he was on before. The lactic acid has come down. He's currently on settings of a respiratory rate of 30 with a tidal volume of 380, which is around 4 cc per kg for him. He's on 100% and then PEEP of 18, sorry. But about 3 hours after, you've been watching this patient, he's your sickest patient, you're watching him like a hawk, you're talking to the family, and you're doing all your serial ARDS management as it should be done for any patient this ill. You're looking at his ABGs, his O2, his hemodynamic status. He's adequately paralyzed. You've got a BIS monitor on. So you see that's next ABG, and it's dropped significantly, right? Your PF has started to go down, and your pH is staying about the same. You get some labs. Your creatinine function has gotten significantly worse. It went from 2.67 to 3.59. Your liver chemistry tests are getting worse. You also notice that the D-dimer is insanely high. Your fibrinogen levels are insanely high. Your white count went from 4 to 15, and your platelets have gone from 140 to 88. So, let's tackle each thing at a time. Number one, what are your thoughts on, let's say we agree that we need to address the hypoxia. What are your thoughts on inhaled pulmonary vasodilators for him?
I would already put him on
First thing I
EPO.
would have, yeah,
I would have already put him on EPO.
yeah.
Right. So are you guys doing
I
it for
would-
any patient that's hypoxic, or the ones that have evidence of RV dysfunction?
I actually expand it to a pure hypoxemic respiratory failure as well as a hypercarbic respiratory failure. So we forget that it's also really helpful for ventilation as well. If you're improving your ventilation perfusion matching, you're not only getting we think about it as an agent that's used for pure hypoxemic respiratory failure. It's actually really helpful in patients who you're having trouble ventilating as well.
I
So
saw
I do for both.
an article recently, I can't remember, I gotta find it, but they were saying like also in patients who are with PEs just to help offload the RV.
Like that's what I'm saying. Like, this guy's an RV failure. He also has ARDS. So he's most likely RV failure from ARDS.
Right.
That being said, his platelet count earlier was lower, and the only thing that wasn't pushing me asking for a peripheral smear when I first saw his labs was the fact that his hemoglobin was like 16. But now that his hemoglobin dropped and his platelets are dropping, I would be asking for a smear, because I still haven't proven. I think that this is ARDS from influenza. There's probably a mixed MRSA component to it, maybe. But in Uday, I would have put a dialysis catheter in this guy right now, because you gotta get volume. You gotta get volume off of him. So you can give him a dose of Bumex, but to be honest with you, my threshold to put this guy on dialysis to offload his right ventricle right now is like crazy low.
So this has been looked at to get a little bit into the literature about early versus late
Please do.
dialysis. I mean, like, we think about, but he doesn't have a hard indication, unless you have failure of diuresis.
Yeah.
I mean, I would give him.
I mean, you got to give him the
Yeah.
the furosemide stress test, which is like 200 of Lasix and 5 of metolazone. And if he pees, he's fine. If he doesn't pee, he goes on immediate dialysis because he has refractory acidosis, right? But Lindsay's right, because if you look at Akiki 2, Start AKI, all of those trials to get enrolled, you had to fail the furosemide stress test.
Yeah, I will say that he did respond. We did do a high dose of diuretics initially, along with given, I'll get to that later, but we did give a gram of solumedrol, and initially he did respond. He put out about 2 liters, but I'm still seeing the same findings on the on ultrasound, which is evidence of RV dysfunction, not some evidence of venous congestion. It's so hard to get the full VEXA scan just because of how obese he is, but still an overall heart rate in the 130s to 150s, and then so I completely agree with pulmonary vasodilators. It was started based on the current vent settings. What are your thoughts on switching to APRV?
The thing is, I mean, it's at some point you're robbing Peter to pay Paul, right? Like you put him on APRV, you may make his oxygenation better, but you're going to crush his RV.
Oh, I'm thinking about your respiratory rate right now, it's at 30, but your total volume is not really optimized. I know we're talking about this being 4 cc's per kg, but this guy, like, I would get him to like 6 cc's per kg and not have him have a respiratory rate of 30 right now, and I would not switch him to APRV because I think that you have very limited wiggle room with that ventilation.
Yeah, I don't think you're going to get enough dump. I don't think with how many dumps you're going to get, I don't think that you're going to get the lung stretch that makes APRV beneficial.
Right on.
You're going to be dumping so quickly that I don't think you're going to get enough stretch to make a difference.
And the risk of atelectasis in this guy, like not having someone at the bedside titrating your APRV, I think is way higher. I mean, I think that would be my biggest fear. So you switch his mode and then someone's not watching it as his compliance improves and now he's like completely atelectatic.
So this idiot fellow who's taking care of him all night, who refuses to leave his room, decides to switch him to APRV, and is watching him like a hawk. If you guys are in the room, I've tried to optimize him with diuresis, tried to address any profound inflammation with high dose steroids, and while I'm waiting for those to work, waiting for the flow lens continue to work, I'm seeing that my evidence of RV dysfunction is not as bad as I think it is because I don't have a crazy amount of venous congestion, and I hate TAPSE. I think that it's a marker that everyone knows, but it only gives you one marker of the RV compared to the entire wall, especially that spherical shape of the RV. And I'm able to somehow get a window in a subxiphoid view, and I push it, in the parasternal long, push it down, and I see a good amount of RV outflow. My RV VTI is equivalent to my LV VTI. It's between 17 to 19. So I'm happy with that. So I don't think that the patient is in overt RV failure, and I decided to pursue APRV. If you guys decided to pursue it, how would you adjust the settings? This is the vents that we use. How would you guys adjust the settings?
I would change. Right now, your dependent variable is T high. You can on the servos, or no, what are these? You can switch your T high. You can switch it to T low and make your T low your dependent variable. So you can just turn the thing is you need your T low to be very low, like 0.5 or less probably. And then everything else will adjust based on what you set your T high, and it will adjust based on what you set your respiratory rate, and then your P high, you're probably gonna have to go above 15. And I would set P low at 0 unless you're not comfortable on setting your T low, in which case I would put your P low at 5.
But I think this vent goes to 3. I think it's like a weird one that doesn't go to 0.
I think they do go to 0.
Okay.
I think they go
It
to
does.
0.
The vent goes to 0. The alarm will come up, and you just have to ignore the alarm.
Oh, okay, gotcha. I know there's one of those.
Yeah, it'll alarm, but you can keep turning down.
Yep.
Yeah.
So yeah, you can put your P low to like 0 or 5, depending upon how comfortable you are adjusting your T low. The problem is if you're not comfortable adjusting the T low, then you need to have some sort of PEEP in there, because if you set it to 0 and you're not comfortable with it, like you're gonna basically take all the people away from this guy, and then he's really gonna.
I'd be willing to bet at a rate of 30, you're gonna have some element of established. The guy who was getting, yeah, I mean, that was what you were using to your advantage, right, in many ways. So I would probably drop it to 0.
Right on, yeah, and so the same thing was done here, right? You know, I'm not a smart person. I like to keep the math simple, so I like to start off with that rate of 12, because then 60 divided by 12 is 5 seconds, and I want the T high plus T low to equal 5 seconds, so I know what I'm doing, and then from there I can, you know, adjust the minutia after that. So, you know, went with like 4.5 and 0.5 for the T high, T low, and then adjusted it from there, and then obviously, like you guys said, kept the P high pretty high with the P low of that. The pulse ox improved. And I was able to get him up from the low 80s to the high 90s. But after an hour, as you guys predicted, his PS starts to drop. And he's got no reserve, even with a little bit of movement, to the point where I'm telling the nurses to no longer do any movement for him now, because I kind of know which direction this is going in. You know, anytime you move him in a little bit, he'll drop to the low 80s and take forever to come back to the 90s. And then, you know, you're getting your micros. Let's talk about this real quick. I think we're all seeing this a lot more. I think we know where the case is heading. You know, his tests for group A strep, you know, have come back positive. You know, you re-examine him, you see this profound rash over his entire body. You're trying to figure out a source. You don't see any open wounds. You can't take a look properly at the mouth right now, but he didn't complain of anything. But you think, hey, maybe this is due to group A strep. How does that change your management in terms of meds?
And the mice and the IVIG. You add it
Right
on.
on, right? You know, Dr. Glassby, Dr. Ward, in your guys' experience, what is your overall consideration of a patient this ill who might have toxic shock?
I mean, he definitely has toxic shock. Like, we've proven it by hemodynamics and by lab work. He's got strep toxic shock.
Right. I agree. I mean, you know, I think we're seeing a lot more of really severe cases this bad that cause ARDS, profound circulatory collapse. You know, and this is exactly what's happening here. Thankfully, he's not decompensated from a shock standpoint yet.
How old was this guy?
33.
So the one point I would make is you rarely see young patients that extremely septic unless they have staph or strep toxic shock or they've got an abscess somewhere.
Yeah.
Right? Like young people don't get this septic unless they have like a necrotizing fasciitis, some big intra-abdominal perf abscess, badness, or a toxic shock. So like when you have young people who are this sick, like this septic appearing, it's not run-of-the-mill sepsis. Like you have to go, it's something else.
Yep, a full physical exam has done. We haven't been able to find any source, but you know the obvious missing one is somewhere inside, and you know it was a battle all night to decide whether to take this guy down for CT or not, and just never got to a point where we felt comfortable enough to take him down given his oxygen reserve.
Were you going to take him down face down? You're going to run through the scanner face down?
No, absolutely not. I mean, he would have to be supine, but that's what I'm saying. It never got to a point where he's stable enough to go to
I don't think
CT.
you can.
No.
I think if a guy's prone, he has no reserve. He's just not a candidate for being able to be moved.
I mean, I guess you could.
They just won't.
They won't.
I mean, you can, right? There's no thing that says you can't. Just you got to convince the nurses and the CT tech and respiratory. Like you're going to have to convince a bunch of people that it's okay to take them down.
And be on the table and scan back and forth, like the actual physical.
I mean, you're more likely to dislodge this tube and or disconnect him.
High risk,
Yeah, it's gonna be sliding back and forth. I mean,
Yeah.
it's like,
So you've adjusted the meds, Vanc, Marum, Clinda, high-dose steroids. You've called for IVIG. It's coming up.
Did you hide the steroids in before you had the strep and everything back?
That's correct. There was a concern.
We were chatting about it. I don't know if I had done it.
Yeah.
Yeah.
This was a consideration based on the rash that we saw. So we couldn't figure out what the rash was from, and I intentionally left that for later. So we can talk about the steroids real quick. You know, it was the rash looked like purpura. And then he did have some modeling at the end, but he was perfusing pretty well. Like the extremities are still warm. And so the concern was that, is this some type of vasculitis, given a history of rheumatoid arthritis in the father? And that was the consideration that, you know, this guy has a profound inflammatory response. You know, he's white count jumped pretty quickly before the steroids. Would steroids make sense? And so after discussing with multiple attendings, we basically made a call to empirically give this guy 1 dose of high-dose steroids. We could talk about IVIG versus Plex. I think as a quick review, the evidence is overall similar. I'm a big believer in Plex because I've seen it work. But just keep in mind that if you decide to Plex this guy right after IVIG, you'll get rid of all those immunoglobulins. All right, he's still hypoxic. He's still critically ill. You guys are both experts in this. What's your guys' next step to address the hypoxia? I'm assuming we're not going to be keeping him here at this community center.
But like, I would have called the second I proned him.
Yes.
All right. So you're calling now for transfer for ECMO, right? You've discussed it with the ECMO transfer center overnight. It does take a while to set all this up. EMS is en route. They've requested obviously to go back to VC plus. And then per the EMS protocol, you've got them on the phone and confirmed this, is that they do require him to be supine for the transfer. This is your gas right before on VC plus for an hour, right before you supinate him. So he's becoming more, if you do the math, he's becoming more hypercarbic. His PFs are still crap. He's perfusing somewhat okay. And then so as the ambulance is about 25 minutes out, maybe even less. We prone him back.
One thing I would mention again is that I know we're using lung protective strategies, but I'm not gonna let somebody's pH drop to 7.1 in transport.
Correct,
So
yeah.
they're gonna be on a tidal volume that's higher than
Yeah, the
like,
tidal volume we
desirable
increased quite a
long-term,
bit. We
but
dropped the rate.
that's to get them through the next hour.
Yeah.
That's.
For the transport, would you also put them on bicarb just to help the pH, just to prevent any problems during transport?
If their last pH is 7.1 and I put them to a tidal volume of like 450, like a decent tidal volume, and yeah, I have to, yeah.
We also
We adjusted the
consider,
minimum elevation from about 10 to about 12 to 13.
Nice. 1 second, Uday.
Yep.
I mean, the other option is to just call a different transfer center and have them come and cannulate him at your facility.
I would at least reach out to them for that evaluation. And granted, there's many reasons why that sometimes cannot happen. And so it wouldn't have me keep them here. I would still have them move, but it's just, I would have an evaluation here.
What were you saying, Uday?
I'm going to move on. We're already running over time, so just give me 5 minutes, and then we'll call it. All right. So there was a consideration of doing either route, right? Do we send him over or do we cannulate him here? Overall, he's hemodynamically stable. He's got the low PF, but he's perfusing pretty well. So we decide let's go ahead and try and transfer him for cannulation. Fortunately, as soon as you flip him, he starts crashing. He gets a significant decline, both circulatory and respiratory collapse. Now he's critically ill. So within like 10, 15 minutes, just to maintain a normal pulse pressure or a normal pulse, he is in multi-pressure shock. He is on maximum doses. And as you continue to try and take care of him, including going up on your pressors, at some point you are on Levofed of 100. You are on Vaso of 0.04. You're on Neo of, I think, about 450. And you're on an Epi of 30. Despite trying to take the Epi off to make sure that there's no tachycardia, his hemodynamics do not improve. There's no change. You are starting to see now that your LV has significant cardiomyopathy. His heart rate is stuck in the 70s to 80s, which is a significant decline from the reserve that he had in the 140s to 180s before. You've given him, IV fluids, you've given him bicarb, you've given him all the calcium, you've given him high-dose thiamine, you've given him methylene blue, and the patient obviously is not stable enough to be transferred. You make a bedside decision. Let me ask you this: are you guys going to flip him back? Because it was as soon as you supinated him, that's when his pressure crashed and his oxygenation got lost.
Yeah, if that was what caused it, then yeah. And they can't cannulate.
Yeah, but right at this point, the cannulation's off the table, right? This guy's not gonna go on ECMO, and to be honest with you, you're putting this guy on VA ECMO at this point, right? But like, nobody's rushing, like nobody comes and puts people on VA ECMO like normally, at least not in this part of the country, right? So you're gonna do whatever you would wanna do. I would have argued that I would have given methylene blue to this guy the second I was adding my third pressor, because in his case, if you're assuming that this is like now IV failure, like, I don't know I'm not a huge fan of, once you're on Neo, if after you went like levo, vaso, epi, vaso, once you're hitting like that next pressor, like, I think whatever's happened is sailed.
Yeah, the attending was here at this point, and he did call for the methylene blue as soon as we started going up on pressors pretty quickly because he knew which way this was going. You know, there's no obvious explanation for why the patient declined so rapidly after supination. You know, hemodynamically, I'm sure there's significant changes. You know, you're changing your venous return, you're changing your cardiac output, and then whatever else is there could have been, you know, just made worse by flipping him over. So things obviously went a bit wild. We did decide to reprone him because we didn't really have an answer for anything else. And you realize that the only chance to save this guy is to get him on circuit. We don't really have any other thing to offer him. He's 33, right? He walked in, he has to walk out. So we do call the heart and lung rescue team. Let's imagine that in this case, Dr. Ward and Dr. Glassby, you guys are the heart and lung rescue team. You guys have arrived with your full set of equipment. We are the fellows, and you're requesting certain things to be prepared. Based on your experience, what stuff are you requesting from us to be prepared at bedside?
I mean, the only way to safely put somebody, because you're really talking about a VA circuit. This is not a VV circuit.
Yeah.
So you're talking about a VA circuit, but like you're talking about a VA circuit in the setting of septic shock. So none of these people do well.
Yeah.
But like it's a much higher
Yes.
mortality than anybody else because they're dying because they're septic. If you're doing that, you have to have a CR. That's the big thing. You really need fluoro for VA.
You have to have
To
what?
safely do VA, you need a fluoro.
Sorry, can you say that again?
You need fluoro, like you need a CR
Yeah.
or something like that.
Yeah.
Yeah.
I mean, the
Is
rest
that
of it
what-
is just asking for the ECMO cannulations, things, and
Yeah.
perfusion and everything, and, you know,
Can you cannulate prone?
no,
No.
they're gonna have to be flipped back over.
Is this something
Yep.
you're gonna be putting a heartbeat into as well?
Hmm?
Will this be something you're putting a heartbeat to RP?
Like a CP, like an LCP, like, are you talking about for like LV venting?
For RP support?
So if you're on VA, you're done, your total heart lung bypass.
Yeah, you're adding like significant heart LV afterload too by putting on VA. So what was done in this scenario is that, you know, obviously 33, they didn't ask any questions. You know, you guys as the heart and lung rescue team came over right away. You got a feeling that maybe the fellow taking care of this patient is a little too obsessed with. He's like,
Oh, I really wish I could have heard that.
Yo, can you repeat what you
Can you repeat that?
the words I heard was, "We have seen way too much toxic shock this last few months."
Yo, you're breaking up.
Oh, no.
That's excellent.
Yeah.
Honestly, this is also most likely gonna end up being a VAB circuit, I think.
Right, because they're gonna beat them. You're not
Yeah.
gonna match them. HYPOXIA.
They brought the catheters out. You know, we kept them prone. We got everything ready to cannulate as soon as we flipped him over. As soon as we flipped him over, we have him on 300 of norepinephrine. We have him on 900 of Neo, 0.06 of Vaso. We're at 15 of Epi, just pushing bicarb and pushing calcium, and we cannulate him. Do you guys have, in this scenario, with the patient this ill that you have to cannulate that quickly, are you guys have any preferred sites that you're cannulating them on?
I mean, it's just, you're just gonna do fem,
Yeah, it's just
but like,
one side.
but honestly, I would, even in a coding patient, like if you're doing like ECPR, like you put a Lucas on them,
Yeah.
they theoretically are gonna be perfused from like a CPR standpoint. But
Yeah.
I would stick to distal reperfusion before I fully put them on the circuit, because the second you put them on the circuit, you're gonna get low blood flow. A lot of the complications I've seen have been when people bleed into multiple stick sites. So I would put one catheter, put like one like holding like arterial sheath in, and then put your
Yeah.
distal reperfusion in, and then upgrade to the full 15 French or 17 French cannula. And this is, this guy's on so much pressure, it's probably gonna be, it's gonna be small. It's gonna be like, 15,
Yeah.
14, 15, it's gonna be small.
Yeah. The person cannulating obviously felt uncomfortable, but they figured that in case the patient had to switch over to VA because they wanted to cannulate VV first, they did right IJ and they did left FEM for VV with a plan to cannulate, save the right FEM for, to cannulate the artery, and they didn't want to double cannulate in the same site. So, and then what they did was they actually cannulated past the right past the central line in the right side without taking it out. So what ended up happening here was I put in a left subclavian while, as soon as we flipped him over, while they cannulated the right IJ, and then the fellow cannulated the left FEM. And then so the other thing they requested was a lot of blood products, knowing that he might have some coagulopathy, given the previous labs. And then as soon as we cannulated him, his pressure started to stabilize significantly. His norepinephrine was cut in half in like the next 30 minutes. As soon as he was on circuit, we were able to come off the epi immediately. We stopped pushing the bicarb pushes. And then the neo also, we brought it down to back down to 300. And he stayed stable until transfer. So yeah, he was transferred on 150 of norepi on the same dose of vaso and the 150, the 300 of neo. As soon as they got him over to the tertiary center that evening, they made a decision to in circuit add in plasma exchange, and that even dropped the pressure requirements even more.
Keep going.
Yeah.
About a week after, he's significantly improved from a hemodynamic standpoint. Almost off press, was obviously on some midodrine, given the amount of vasoplegia that's probably just going to be persistent for a while. And given his obesity and the amount of sedation, paralytics that he was on at high doses, he takes a while to wake up, but he does wake up. Given his overall reserve, he does end up getting trached due to difficulty extubating. I mean, considering how ill he was, that makes sense. But the part that was most surprising to me and just profound for me to hear is that about a month after he was decannulated, the guy walked out of the hospital with a full neurological recovery. And that to me is just profound. And it just shows, when it comes to, the people I was speaking with, is that from the ID standpoint, they all really push that the inflammation from toxic shock is just so profound that these guys actually recover. They ended up doing a full workup and never found a source. So maybe it was the flu, maybe it was likely, group A strep, likely toxic shock, but I think in this scenario, everything was thrown at him and the guy somehow survived this. And then, I think around the same time, just as, an interesting story, I think the same day, this was New Year's Eve, I think you guys might have taken care of the patient's father who also dealt with the same thing, but didn't have as good of an outcome, probably due to his significant age. But it really goes to show, Jared, like you said it, right? When it comes to these young guys, you throw everything at them, right? They walk in, they have to walk out. Do you guys have any final thoughts?
No, I was just wondering why when you put him on VV, aside from the severe hypoxia and acidosis, theoretically he shouldn't have just gotten better with VV alone.
Yeah. I think the thought process there is that the cardiomyopathy was all being caused, and then there's all these lectures on this, and I've listened to them, and it makes sense, is that the amount of inflammation being caused by the disease process here is so profound that it causes an innate profound catecholamine stress in the LV, and that's why you were seeing that LV eventually breaking down, and that's why they call it septic cardiomyopathy. It's just constant stress, and the moment you take away that stress by getting rid of all those inflammatory mediators, even for a short bit by getting them off circuit, by really physically removing it from the blood by being on circuit, your pressure requirements improve dramatically, and your LV function also improves. There was a concern that by putting on VA, that little reserve that he has to be stable and tolerate VV would be taken away. And so they wanted to try and ride it out and see what happens. And literally what they told me was that, in the unit, they had about 4 people on circuit, and this was the one they refused to leave the entire time he was there, at least the next 24 hours.
Well, great job.
Thank you guys so much. Really appreciate all the expert opinion. For everyone else, thank you guys for listening. I know you guys have had to listen to me all year, more than you would have liked to, but appreciate all the enthusiasm, all the excitement. The lectures were really fun to prepare. And then, for the first years, we'll see you guys at the graduation party next week. Thanks all.
Thank you.
Thank you, Vanessa.
Are you
Yeah. Yeah. I don't have to go.